All right, good morning, everyone. I'd like to welcome you all to today's webinar today, titled Bronchiolitis, Navigating the Ever-Changing Treatment Landscape. We do have quite a bit of material to get through, so I'm just going to go ahead and jump right in. Let's go ahead and go to the next slide, Dr. Russell, if you don't mind. This is a reminder that this presentation is being provided in English with simultaneous interpretation into Spanish. So if you prefer to listen to the presentation in Spanish, at the bottom of your screen, there's a globe-shaped icon. Click on that icon to select the language that you would like to listen in. Likewise, if you would like to view the Spanish slide deck, at the top of your screen, there is a tab that says View Options. Click on that tab, and then you can select from there whether you would like to view the English or Spanish slide deck. Next slide, please. Migrant Clinicians Network is an accredited provider of continuing nursing education. We have also submitted an application to the American Academy of Family Physicians for any physician who would like to receive continuing medical education hours. We also offer a certificate for promotoras and CHWs. So please, in order to receive either a CNE, a CME, or a certificate of completion, you do need to submit the evaluation, and we will provide you the link to the evaluation at the end of this presentation. Next slide, please. And in order to comply with the accrediting agency's requirements, we do have to inform the audience that we have no real or perceived vested interest that relate to this presentation, nor do we have any relationships with pharmaceutical companies, biomedical device manufacturers, and or other corporations whose product or services are related to pertinent therapeutic areas. Next slide, please. And with that, I'd like to present our speaker for today, Dr. Eric Russell. Dr. Eric Russell is an assistant professor of pediatrics at Baylor College of Medicine and a pediatric emergency medicine physician at Texas Children's Hospital. After his pediatric residency at Children's Hospital of Philadelphia, Dr. Russell completed a combined pediatric emergency medicine and global health fellowship at Texas Children's Hospital in 2016 and remains there as faculty. His academic interests include global health and immigrant health, with ongoing projects in Latin America, the southern US border, and to improve the health of newly arrived immigrant children in Houston. And with that, I would like to have Dr. Eric Russell take it away. Dr. Russell, please.
Great, thank you very much.
Thank you so much.
For that introduction, and thank you for inviting me here. I'm excited to talk about bronchiolitis. Nothing gets pediatricians excited more, gets people talking more than bronchiolitis. Maybe asthma, but close second or first is bronchiolitis. So I'm looking forward to it. It's also something that causes a lot of difficulty for families, for the care team, and lots of consternation, as it can be difficult to know what the correct thing to do is sometimes. So I'm hoping that we will talk about some of those sticky points today. So our objectives, we will talk about some clinical aspects and presentation of viral bronchiolitis, with in particular highlighting RSV, COVID. We will consider the evaluation of other comorbidities, meaning what do you do with a febrile 3-month-old who has bronchiolitis? What other tests might you consider? And thirdly, we'll talk about the treatment options, of which there are many, and unfortunately not all are helpful. So we'll talk about some of the medical management as well as respiratory support. And then lastly, we'll touch briefly on discussion around barriers or concerns for underserved communities. So jumping right in, so bronchiolitis, as we all know, is super common. It accounts for about 15% of all hospitalizations in children, 15% of all ER visits, especially in the younger kids. It is consistently the most common cause of admission in children under the age of 1. And can be caused by any virus, but RSV far and away being the most common cause that people will come to the ER or get admitted to the hospital. I'm just taking a moment to look at RSV in particular, given that so much disease is caused by RSV. It's very hardy. It can exist on surfaces for hours and survive, requiring contact isolation for those that do have RSV. Humans are a natural reservoir for RSV. 50 to 60% of all kids are infected in their first year of life, and up to about 90% by 2 years of age. So everybody gets it. There is some regional variability, as I'm sure everybody is aware. You can see this is from the Texas Children's Hospital, our positivity rates over the last year. You can see our RSV season has slowed down tremendously by now. Went September to January, we're quite busy. And our flu also has slowed down quite a bit. But this is variable by where you are in the country. So those up north might still be in the throes. COVID and bronchiolitis. Prior to COVID-19, coronavirus infections did cause bronchiolitis, but were tended to be less severe and were more in hospitalized kids tended to be a co-infection with RSV. In the COVID-19 era, I would say we're not seeing a ton of severe bronchiolitis per se. It's not to say that we aren't seeing kids that are infected, obviously, but with bronchiolitis, as in lower airway inflammation, when we see it, is less common and less severe than say RSV virus. But it certainly can happen, but fewer hospitalizations and generally more mild, fortunately. Croup, on the other hand, is super common with COVID. Those of us that work in the ER, and probably many of you have probably seen this or noticed this association with upper airway inflammation or croup. This graph here is from a hospital from Mass General, I believe, up in Massachusetts, that was looked at their COVID positivity rates, and so you can see a spike with Omicron towards the right-hand part of this graph, and also their visits for COVID. So quite a bit of COVID associated with croup, or quite a bit of croup associated with COVID. So what is bronchiolitis? How do we explain it to families? How do we understand it ourselves? So bronchiolitis is really, it's a lower airway inflammatory condition. Viral infections cause direct damage, direct infection, and inflammation to the epithelial cells of the distal or smaller airways, bronchi and bronchioles in particular. It causes edema, mucus, sloughed off cells, leading to inflammation, obstruction, decreased airflow. So this is what you're hearing when you hear this sort of rattly, coarse breath sounds of little kids with bronchiolitis. It's all of that mucus and inflammation, ultimately leading to an obstruction of their distal airways, which is important when we think about a lot of the medications that have been tried that we've had a difficult time relieving that obstruction, and ultimately leading to decreased airflow and increased work of breathing. Deaths with bronchiolitis, fortunately, are fairly uncommon here in the US. This data is a little bit old, but from 2000 to 2011, they looked at hospital discharges with bronchiolitis, and you can see the death rates there, and they decreased over that time period to about 4 in 10,000. Worldwide, it's a little bit of a different story. There's a much higher burden of disease and death in resource-constrained countries, with an estimated 200,000 worldwide deaths, but it's probably an underestimation would be my guess. There are, here in the US in particular, for kids that unfortunately pass from bronchiolitis, majority of them, or a significant percentage of them rather, have underlying complex health disease that complicates their course, such as underlying heart disease or lung disease. So what do we see with bronchiolitis? So those of us that take care of kids, you probably can do this in your sleep and just know this in your in your heart and in your soul. But what do we see? So the typical course is usually several days of cold symptoms, of runny nose, maybe they have fever, before things really ramp up. And I think this is important when we think about counseling families, and also when we see kids during the heart of their illness. Frequently they will say, I'm in the emergency room, they'll say, well, the first couple of days they just seem to have a cold and now they're really sick. Well, that's normal. It's a normal progression of disease, where they tend to get worse around day 3 to 5 is the peak, where they develop cough, increased work of breathing, potentially retractions, tachypnea, they may wheeze. There's a lot of moment-to-moment variation. And so a lot of families come in and they say, I swear when we were at home, he was working a lot harder, or she was working a lot harder. And that's normal. Things change from minute to minute. And then after about days 3 to 5, things slowly improve. But again, when you're talking to families, you can see here from this graph below in a study that was published in The Lancet by Todd Florin, the symptoms continue for quite a while. And so counseling families that the worst of it is going to be in that day 3 to 5, but can expect the cough to continue for up to potentially 2 weeks plus. Also think about, with this graph, how does your thought process change from a patient that you're seeing on day 1 of illness who's already tachypnic to a child who maybe is on day 8 of illness who's tachypnic. So our assessment for patients with bronchiolitis, and I apologize to Noel, I just remembered that I'm supposed to be saying next slide to keep the Spanish on track, the Spanish slide deck on track. So I will start to do that, or do my best. I'm focused so much on speaking slowly for the interpreters, I forgot to advance the slide. So anyhow, so what do we do when we're looking at a patient with bronchiolitis? What are the things that we're looking for to think of who are the kids that we need to worry about or be concerned about? The first and foremost, the way that I explain it to families is there's really 3 main ways that kids with bronchiolitis get into trouble. The first is with their work of breathing, meaning are they breathing too fast or too hard? How severe are the retractions? Are they just sort of mild subcostal retractions, but they're otherwise healthy, or are they really pulling and tugging? Are they, have retractions in other locations? Wheezing itself is not a predictor of severity, meaning we have these lovely kids that we refer to as happy wheezers. So these kids may sound terrible, but they're happy and breathing comfortably. So wheezing and how they sound is not a predictor of severity. The second way is with their oxygen saturation. So generally we get worried when kids are less than 90%. And generally speaking, kids that are breathing super comfortably, they're, for kids that are hypoxemic or have low oxygen levels, generally also have associated increased work of breathing. And then their hydration status. So how are they doing eating and drinking? What is their daily urine output like? So that's what I describe to families as the 3 ways that kids with bronchiolitis get into trouble is their work of breathing, oxygen levels, and their hydration. And then from your own assessment, looking at their mental status. So once they're really sleepy and lethargic, then we get much more concerned about their severity. So I want to look at 2 videos here. I apologize, the sound might not be working. See, hopefully the videos will work. We will try it. Oh, here we go. So we're going to look at 2 videos with 3 kids. These are not my videos. So this child, what is it that you notice when you look at him or her? First and foremost, I notice the lethargy. This child is not vigorous. They're not moving. You can see somebody is working to place an IV. Heavy retractions. He's really tachypnic. In this particular case, you can see that his gas, they show his gas here, which you often won't have, but his pH is 7.2 and his PCO2 is 75. this child at a minimum needs CPAP, BiPAP, and probably needs to be intubated. For certainly needs higher level of care if you're not able to provide that. But this is a really sick kid. This mental status is quite poor. The second patient, pardon me while I migrate to with both kids, I'll point out, they're getting, probably albuterol or something here. That first kid had a face mask on, which, is not, he needs more significant support. Maybe they just walked in the door. I have no idea, but both of these kids need a little bit more support. So what do you notice about this kid? He or she is more vigorous. You can see she's got her arms up. She's not great. She's got her eyes closed. She's coughing frequently. That is a very classic bronchiolitic cough. The mom mentions in the video, you probably can't hear, that she's eating well. Her work of breathing is increased, but not as severe as that first child. So this kid needs some attention, but I would say is not anywhere close to the severity of that first child. What about this third one, the third video here? Again, excuse me while I try to find the right spot here. Not this one. You can hear that sound here. It's a classic bronchiolitic lower airway. You probably can't hear it. I'm sorry if you can't hear it. So this kid, what do you notice here? So if you can't hear it, this kid is super wheezy. He sounds terrible, but he's smiley, he's happy, he's awake, he's alert, he's looking around. We can't really see his retractions under his clothes, but you can imagine that it's probably not severe. He looks well hydrated. This kid looks like he's ready to eat, right? So my point with this third one is he sounds terrible, which you can't hear. I apologize, but he looks great. So that's reassuring. Okay. I'm sorry. Okay, so for patients with bronchiolitis, other things to think about. So the duration of illness. So these are things you can kind of think about in your head as far as how you're going to treat them or triage them, perhaps. So if you have a kid that, that second patient on day 2 of illness, I'm much more worried about them, because you can probably guess that the worst is yet to come. And as opposed to somebody on day 5 or 6 of illness, where you're probably looking at the worst of it, or potentially the worst is behind you. So that may help. Do they have underlying medical conditions, heart disease, lung disease? What is the parent's ability to take care of them? How far away do they live for medical care? Do you have other concerns that might make you worry that they might not be able to come back if they get worse? What about viral studies? We'll talk more about this later, but is a RSV test on this child going to help? Is a chest X-ray going to help? The short answer to that is that the viral studies often make things more confusing rather than helping. We see a lot of kids in the ER that get tested for rapid RSV flu and they're negative, and so there's concern that well what do they have? Well, the sensitivity of those tests aren't perfect, and of course there's many other viruses out there that can cause it. So sometimes it causes confusion, and generally not helpful. And then I want to take a quick moment just to point out, I'm not going to spend a lot of time on this just because we have a lot of other material, but remember that not all respiratory distress is bronchiolitis. This is really hard during bronchiolitis season, but this is a great time for kids with cardiac disease to present for a couple reasons. Sometimes they just will confuse people, or there's a lot of overlap with how they look. They're breathing fast, they're not eating well. They may even have some rails on exam if they're in failure or overcirculation. Or what often happens is that kids with underlying cardiac disease are maybe doing okay, and then they get a cold on top of that. So they may very well have a viral infection, but that was what tipped them over the edge. So they were doing okay before, and then they get a cold and they can't handle it. And so they present. And so I have caught a fair number of undiagnosed cardiac disease. This is a picture this is not a picture of my patient. It was on the internet, but in this case, this is a child who is mottled, maybe ill appearing, and breathing fast. But in particular, what made me want to highlight this case is that I had a child who was breathing really fast and looked bad. But then you listen to him, and he did have some rales, probably from pulmonary edema. But usually in kids with bronchiolitis, when they look that bad, they sound terrible. This kid really didn't sound bad, just a little bit, but looked terrible. So I've had two patients like this who presented with Al-Kappa, also known as anomalous left coronary artery from the pulmonary artery. And so they basically get repeated heart attacks, for lack of a better word, poor perfusion and eventual heart failure. More commonly, this is a less common diagnosis, but I've had a fair number of undiagnosed VSDs or ASDs that are really big. So they don't have a murmur, but that can tip them over the edge. So it definitely happens. So moving on, so looking at chest x-rays can be hard. We definitely, the recommendations are not to get a chest x-ray on every bronchiolitic, primarily because they often confuse the diagnosis rather than make it better. These kids get a lot of atelectasis, edema, all that mucus and sloughing and inflammation that we talked about shows up on x-ray. This one may not project terribly well, but there may be increased lung markings. So then you get stuck wondering, is this pneumonia? Is this not? So chest x-rays are associated with increased pneumonia usage. Right upper lobe atelectasis, you can sort of see this wedge shape here is very common, especially in the little ones. Increased perihilar markings or increased fluffiness, for lack of a better word, around the hilum or just around the heart on the left and the right. Same thing here. So these kids, none of whom have pneumonia, but you can see it can be very difficult. Okay, so who are the kids that are at increased risk for having severe disease? We know that this is part of your assessment to say who are the ones that are going to get into trouble. So those that are premature, are low birth weight, are really little, so that you're going to worry a lot more about the 4-week-old than you are about the 16-month-old. Do they have underlying other conditions like we talked about? Are there social factors? Smoking has been associated with increased risk. Daycare and older siblings, probably just because of increased disease burden on those little kids. You can't keep them free from the snottiness. Timing of birth, were they born right before RSV season? Next slide. Sorry, I'm going to try again. What about apnea? This is the one that scares everybody. Who are the kids that are going to stop breathing? This was a study that looked at about 2,000 hospitalized children, so presumably a sicker cohort. And it was a prospective study, looked at about 2,100 kids. To see who were the kids that were going to develop apnea during their hospitalization. And the ones that did, perhaps not terribly surprising, were premature, were really young, had a really high respiratory rate or really low respiratory rate, probably much more concerning on presentation, more hypoxemic, and had comorbid conditions. I would say that we will, interestingly in this study, RSV was not high, it was not more associated with apnea than other viral pathogens for the risk of apnea. So, we have a lot of kids that come into the ER with RSV and they're, 5 weeks old to evaluate, to watch for apnea. It's really not an indication, if they're otherwise healthy and they don't have any risk factors and they look okay, there's really no indication to hospitalize them just on the off chance that they have apnea. they really need something else. The kids that I've seen that have gone apneic, they're sick. They're not smiley, happy kids that all of a sudden stop breathing. They're sick before they stop breathing. And then overall, in all patients with bronchiolitis, about 5 to 10% will require respiratory support, hence all of the ER visits and hospitalizations. Unfortunately, 1 to 2% will require intubation. We talked about the mortality rate. As I said, there's no evidence for routine admission of neonates who are RSV positive, but have no other concerning signs or symptoms. Next slide. All right, so here's the hard part. So this to me is the hardest part about pediatrics in general, also true with bronchiolitis and with viral illness. So most kids are healthy and are going to do great. Most just have a cold. So who are the kids? We have to find the needle in the haystack. Who are the kids that are going to get sick? Who are the kids that have something else going on? Who are the kids that we really need to worry about? This is really hard. So I want you to ask yourself, let's say you're seeing this patient in your office or whatever setting you practice in. First one is a 6-month-old female with a runny nose. What are you going to fever? What else are you going to do for her, if anything? What about the 3-week-old with a fever and a runny nose? And I want to make a quick distinction in that bronchiolitis is not the same thing as a runny nose, right? Bronchiolitis is lower airway disease, lower airway inflammation. That said, over the next couple of minutes, next slide, over the next couple of minutes, I am going to conflate the two topics a little bit as far as who are the kids with bronchiolitis and who that also are at risk of serious bacterial infections. I say that I'm going to conflate the data a little bit because some of the data that I think is pertinent to this conversation just looks at viral positivity and not necessarily bronchiolitis. But we'll separate them out when we can. So bronchiolitis and the risk of serious bacterial infection. So this is, as I say, this is the hard part. So every kid that that you see or that I see that has a fever, our first question is, while most kids have a cold, what is their risk factor a priori? What is their pre-test probability? What is the likelihood that what is their risk for having a serious bacterial infection just walking in the door? I think that may help a little bit with risk stratifying patients in that a 7-year-old vaccinated, healthy, well-appearing child, their risk of serious bacterial infections is much, much different than a 3-week-old with fever just walking in the door before you even do an evaluation. And that may help a little bit with your workup of patients, but so that's what I do. So the problem with bronchiolitis is that 30% are going to have a fever. There's a wide variability with practice patterns with how we, as a medical community, evaluate things like urine, blood, CSF. But we know that viral illnesses can damage natural barriers. Nobody likes checking a urine on a child that's super snotty and maybe even has bronchiolitis. Nobody likes checking blood tests, but we know that viral illnesses do put patients at increased risk for bacterial illnesses. And as we said before, the symptoms of bronchiolitis can persist for weeks. So what are the chances that that 3-week-old or 5-week-old or 6-week-old who had bronchiolitis a week and a half ago now developed urinary tract infection when we know UTIs are so common? So that's the hard part. Is it bad luck? Sure. But does it, as I mentioned, we know that viral illnesses can put people at increased risk for bacterial illness. In particular, there's excellent data with influenza and group A strep. And so we've had cases of patients that have tested positive for the flu and undoubtedly have the flu, who also end up developing group A strep bacteremia and get very, very sick or die. And this is a very well-known association dating back even to the great flu pandemic many years ago. One of my infectious disease colleagues was recently telling me that when they exhumed bodies and tested them, had higher rates of group A strep and pneumococcus from the Great Flu. So it definitely happens. But of course, there's a risk to evaluation in and of itself. There's a risk of the test, you get false positives, doing a urinary cath on a baby, it's invasive. You end up getting increased antibiotic usage, unnecessary admission. So it's not benign. Next slide. So this is a study that looked at serious bacterial infections in febrile infants up to 90 days of age with and without viral infection. So this is one of the ones I was referring to that they just looked at viral positive, viral negative. It wasn't specific to bronchiolitis, although some of them probably had bronchiolitis. So in this cohort, they had many more results than this, but just for the purpose of this discussion, out of the 1,300 infants, 35 tested positive for a viral illness. The serious bacterial infection rate in the viral negative group was 12%, so quite high. In the viral positive rate, it was significantly less, it was 4%, but 4% is not nothing, right? You know, it's 1 in 25, right? It's not that low. Generally speaking, for definition purposes, serious bacterial infections are usually, these are the more common infections that you can't easily see with your eyes and ears, right? So it doesn't include skin and soft tissue infections. Pneumonia, theoretically, although with bronchiolitis, it can be hard, can be a clinical diagnosis, or is a clinical diagnosis in some cases. So generally speaking, for research purposes, serious bacterial infection would be things like meningitis, bacteremia, urinary tract infections. Some studies have even gone further and said invasive bacterial infections, which we have one study here. That takes out the urine because the urine is relatively easily obtained and interpreted. So looking at bacteremia, meningitis. So this study looked at the risk of serious bacterial infection in patients with RSV. Again, here we have 1,200 febrile infants less than 60 days. 270 were RSV positive. You can see the SBI or bacterial infection rate of 7% in RSV positive versus 11% in the RSV negative group. So those febrile infants who tested RSV negative had bacterial infection 11% of the time, and the ones that were RSV positive still had a rate of 7% in less than 60 days. That's really high. The bacteremia you can see here was 1 versus 2%. Most of that serious bacterial infection was coming from urinary tract infections. You can see here was 5 and 10%. So that's the majority of the bacterial infections they were finding. Again, this is less than 60 days. And the bacteremia meningitis rates were not statistically significant in this group. Next slide. So another study here that looked at 60 days and younger. Same thing, about 3,000 febrile infants who had this was just looking at viral infections in general. Saw similar numbers. So 12% bacterial co-infections in the viral negative group and about 4% in the viral positive group. The bacteremia was again 1 and 3%. Urinary tract infections was a little bit lower in this study, but it was about 3% versus 11%. And again, the bacteremia meningitis was not significantly different. What about bronchiolitis in particular? So all those other ones were just viral positivity. This study looked at bronchiolitis in particular and urinary tract infections. So they saw that. I think this is super interesting. They had 800 patients with bronchiolitis. Mean age was 3.5 months. They were a young group, which are the kids that we worry about. So they were the young groups, it was appropriate. In the RSV positive bronchiolitis patients, UTIs were still found in 6%. So that's 1 in 20, right? So how many, if you're in a busy pediatrics practice or family medicine practice, how many kids with bronchiolitis do you see in a week during bronchiolitis season? It's probably more than 20. And then, of course, with other viral positive bronchiolitis, the urinary tract infection rate was even higher. It was higher than in the viral negative group. But I think the take home there is that even in the viral positive groups, even in RSV positive, the rates are still high. What about COVID and serious bacterial infections? Next slide. This is harder. We don't have a lot of data on, even though COVID's now been around for a couple of years, we don't have a ton of data on COVID and coexisting serious bacterial infections. But this study looked at, it was only 200 patients, less than 60 days, who were hospitalized with fever, again, not necessarily bronchiolitis. This was during Omicron. In this group, in the COVID positive group, they saw a serious bacterial infection rate of about 2%. COVID negative group, about, in hospitalized patients, about 19%. Again, this is a small group. We don't have a ton of data. This study is a little bit busy, but similar, looked at co-infection in young infants. I want to highlight just a couple of things. You can see in the very top line with serious bacteria with less than 28 days, even with COVID positivity, they still had a 10% rate of bacterial infection, really high. And the COVID negative group was about a quarter. This was not statistically different, but still very high. In the older kids, so this is probably 1 to 2 months, it was 5% and 22%. This was statistically significantly different, but the point that I take away from this is it's a pretty high rate. Most of these are urinary tract infections, as you can see, with low rates of bacteremia and meningitis. And here they made this distinction of this invasive bacterial infection, which again pulls the UTI out of it. So what do we do with this information? What is our workup going to be? This is from our Texas Children's Hospital algorithm. You can, which is not publicly available, unfortunately, but other children's hospitals are CHOP. I think Seattle Children's is Children's Hospital of Philadelphia. So this is in kids 0 to 21 days with fever. Basically, they get everything. So a positive viral test, including COVID-19 or bronchiolitis, does not exclude them from workups. As we just saw in the previous slides, they still have very high rates of bacterial illness, including invasive bacterial illness. In the older kids, it's a little bit harder. You can see here that on our algorithm, bronchiolitis is an exclusion criteria, meaning that this does a diagnosis of bronchiolitis, not a cold. Bronchiolitis, lower airway disease, does exclude them from additional workup. A positive viral test by itself, including COVID, is not an exclusion criteria. As we just saw, still very high rates. There's debate and difficulty with bronchiolitis. I will say that my own personal practice is that even with bronchiolitis, I still check urine. I may not check blood, but I'm definitely checking urine for the reasons that we just talked about. So what's the bottom line? So this is pulled from a clinical practice guideline from the AAP that showed, and I'll just read it, that numerous studies have documented lowering the invasive bacterial infection risk in a subset of patients. However, no prospective study has yet provided convincing data on whether a positive viral test sufficiently reduces the risk to change your decision-making after considering other factors. So I would say, the take home to this is, even in patients with bronchiolitis, especially if they're young, you should consider urine. So if you have a 3-month-old girl who has a fever to 102.3 and has bronchiolitis, I'm checking a urine on that kid. I just am. It's still really high. If it's a 18-month-old, maybe I have a conversation with the family and say, there's still some risk, but you got to weigh the risks and benefits of the cath in that patient. So consider their risk factors. Hopefully the last couple of slides have helped delineate that a little bit for what their risks are. So sorry, I just said some of this, but so the rates of serious bacterial infection is not negligible. In kids less than a month, they get everything, regardless, as if you hadn't done the viral test. In kids under 2 months of age, you can probably treat them a little bit different, but at a minimum, get a urine and urine culture. And then after that, it's just up to your clinical decision-making as to whether or not you need to do blood or CSF or whatnot. And again, this is in well-appearing kids, right? If you have a kid that's super sick, that's all bets are off. All right, what about other testing? Chest x-rays, not routinely recommended for reasons that we talked about. CBC and blood cultures, not routinely recommended unless you're doing a sepsis evaluation. Blood gas, not routinely recommended unless you're worried about impending respiratory failure like they had obtained in that very first video that we watched. All right, so let's transition a little bit to some of the treatment modalities. I know this is the part that I think causes so much difficulty for a lot of reasons, a lot of good reasons. The bottom line is a lot of this stuff just unfortunately just doesn't work very well. So what about albuterol? So this was a meta-analysis that looked at 28 studies. The kids that received albuterol had no improvement in their oxygen rates, hospitalization rates, duration of illness, or time to resolution. There were some studies that did show some benefit to their respiratory score. So like they looked more comfortable, but this was very mixed at best. Again, I think that, using your some degree of, how do I put this? So if I have a 20-month-old and everybody in the family has asthma, okay, fine. I'll probably try albuterol on that kid. If I have a 3-week-old who's in respiratory distress, I'm not going to try albuterol on that kid. I'm just going to give them positive pressure, right? So, there's a little bit of variability in there, but, in general, we way overutilize it. It gets prescribed constantly, and generally it doesn't help. What about racemic epinephrine? The data is even a little bit more mixed on this one, but similar conclusions. There is some data that shows maybe some decreased hospitalization on the day one, but not sort of looking at the big picture. Another study looked at epinephrine and dexamethasone, and there was maybe a little bit of decreased hospitalization on day 7 of illness when looking at the whole cohort. There's some data to suggest that maybe it reduces respiratory effort in the moment, but doesn't have a bigger impact. So a lot of people question as to whether or not we should be doing this in the ER and then they look better and we send them home, right? And what's going to happen after that wears off in 3 hours? There may be some role in cases of severe distress as a rescue effort, but it hasn't been well studied. What about steroids? This one's another one that we see a lot. They get treated like asthma. The results are even worse with this. No decrease in hospitalization, length of stay. Inhaled corticosteroids don't help. No decrease in admission, length of stay, and that second meta-analysis that I quote there. So at this point, national and international guidelines do not recommend the routine use of corticosteroids. Again, that 20-month-old who everybody in the family has asthma, super responsive to albuterol, sure, I'll treat that kid. The 4-month-old, no chance. Okay. What about positive pressure and respiratory support? This is another area that people love to get upset about, myself included. So what are the options? There's standard low flow nasal cannula, as well as high flow nasal cannula and CPAP. So what does high flow nasal cannula do? We use it all the time in the hospital setting. Increased comfort, potentially decreased effort. Maybe it provides a little bit of PEEP, positive airway pressure. Carbon dioxide washout in that anatomical dead space. You can give a higher oxygen concentration. But does it work? That's always the question. So again, this slide looks at what does it do, compares the conventional oxygen. This is just your standard nasal cannula versus high flow versus CPAP. I want to highlight there in the middle that your high flow as compared to CPAP it may generate some, but probably not as much end expiratory pressure. Your standard oxygen is not going to give you any PEEP or end expiratory pressure. Maybe it reduces some work breathing. It will probably wash out dead space better than other modalities and hopefully reduce your work breathing. Unfortunately, results are kind of mixed here. With high flow nasal cannula versus CPAP, this 2021 meta-analysis compared CPAP and high flow and found higher rates of treatment failure. There was less adverse events, mainly nasal trauma, but and similar outcomes with respiratory distress and length of stay. It's that length of stay that gets a lot of people worked up, that the high flow seems to increase our length of stay. These results have been shown in other studies that have confirmed basically the same findings. What about high flow versus just your standard low flow? In patients in this study that looked at the two, they didn't find a difference in treatment failure, which to me says that they worked equally poorly, right? Both of them had the same rates of treatment failure. So high flow was not, in this particular study, was not making people better. There was no difference in PICU admission rate. So kids were not more likely to stay out of the ICU on high flow. There was some improvement in respiratory score, meaning they looked a little bit more comfortable, which to me is important. And then a second RCT found that in addition to not helping with treatment failure, ICU, all they found was that it increased your length of stay. So this is the main argument for people that don't like high flow. I like that it may reduce respiratory effort in some patients, and it undoubtedly does. So it'll make people look more comfortable. In this study, this was another meta-analysis done more recently. I'm sorry, I don't have the date up there. This was 2021, 22, something like that. That looked at high flow. This study did find that there was some reduced treatment failure as compared to nasal cannula alone. But there was increased treatment failure as compared to CPAP. So it doesn't work as well as CPAP in our sicker kids. So what are the take-home points of all this? At the end of the day, the bulk of the evidence suggests that standard oxygen and high flow are probably similar, especially in your mild to moderate bronchiolitis patients, with high flow increasing your cost and length of stay. So most, if you need something, could probably manage on low flow. But for sicker kids, like that very first video we watched, for sicker kids, that kid was on a face mask, which was not providing any pressure. But again, maybe he just walked in the door. That's fine. But for sicker, younger, higher risk kids, we probably should be putting them on CPAP faster. You can certainly use high flow nasal cannula, but we're probably using it too much in general. So for more mild disease, we can probably get away with standard O2, if anything, or maybe we just tolerate a little bit of tachypnea and they'll get off weaned faster. And in more severe disease, we probably should be doing more CPAP. All right, what about bronchiolitis and diverse or underserved communities? This one, I think it was tough. We wanted to, as we were planning for this webinar, wanted to spend a few minutes talking about this and talking about bronchiolitis and its impact on different communities with the different social implications that it might make. But I quickly realized that this could be an hour discussion in and of itself, probably a several-day discussion in and of itself. But I think there are some important issues to raise at least and to think about, but we're not going to have time to sort of fully explore it, unfortunately. Maybe the next webinar. So much has been written over the past couple of years, especially in the era of COVID-19. about the burden of disease in different communities. As I said, this has been highlighted with COVID. As we know, different communities experienced COVID differently and had a disproportionately, especially early on in illness, disproportionate and high burden of disease. The reasons for this, as I said, have been well written and discussed and are varied, include housing characteristics, employment, ability to stay home when you're sick, ability to stay home with sick kids. And so certainly this must be true with other viral illnesses and bronchiolitis in general. Similarly, with bronchiolitis, we know that Hispanic and Black families and patients are more likely to present to the ER and get hospitalized. Presumably that this has something to do with the discussion that we just had about increased burden of disease, increased exposure, but probably has something to do with things like access to care and other social determinants of health. In addition, multiple studies have shown that there are racial and ethnic differences with how people are treated. The results are mixed, but some studies have shown increased albuterol and steroid usage in Black and Hispanic families, Black and Hispanic patients, whereas white patients are more likely to get chest x-rays. Interestingly, there was a very recent study here in the Houston area that looked at social vulnerability index. The CDC has a social vulnerability index based on their census tracts. They did not see a difference in PICU admission or length of stay, but they did see increased risk of hospitalization for larger households, so more family members per household, which again kind of makes sense with what we mentioned at the very beginning, that if you're a 4-week-old and you have an older brother or sister who's in daycare, you're much more likely to get sick than a 4-week-old that doesn't have any siblings. And then lastly, I wanted to highlight pulse ox. I think this is a growing area of study that I think we're going to be hearing a lot more about in the coming years. And there is a little bit of data out there now, but I think there'll probably be more to come. But there have been studies to suggest that that our commonly used pulse ox devices overestimate blood oxygen levels in patients with darker skin tones. So what does this mean? This means that that we would be less able to recognize mild to moderate hypoxemia in patients with darker skin colors. There are some larger studies that are just getting underway, one of which is here at Texas Children's, to look at darker skin colors and how we recognize hypoxemia. Interestingly, there's more data used internationally, in studies that have been done in global settings, looking at this issue, but I think we're going to be hearing a lot more about this to come. But at the end, I think there's, clearly much we don't understand about social factors and their impact on bronchiolitis and other viral diseases. But what we do know only continues to emphasize the importance of getting vaccinated, especially in diverse communities who shoulder the burden of this and other diseases. As I mentioned at the beginning, we know that bronchiolitis outside of the United States has caused a huge burden of disease. RSV in particular, huge numbers of kids are infected, many hospital admissions, and probably an underestimation of about 200,000 deaths. The vast majority of these deaths are occurring in resource-constrained settings, developing countries, which is unfortunate because, of course, most kids recover just fine with the appropriate support. But if you're in a hospital that doesn't have CPAP or ventilators or high flow for that matter, what are you going to do? So in the last couple of minutes, I'm not going to spend a lot of time on this. What do the guidelines state? This is just the AAP recommendations. It's pretty much everything that we've talked about. Bronchiolitis clinical diagnosis, the risk factors for severe disease in the young, otherwise kids have underlying medical conditions, We should not be doing routine chest x-rays. We should not be doing routine viral testing. We should not be giving it albuterol to infants routinely with bronchiolitis. We should not be giving epinephrine routinely to kids with bronchiolitis. So again, this is sort of routine administration. If you have an older kid or somebody that's really sick, you can make your clinical judgment. We do recognize that there's a small subset of patients, probably the older kids that have a lot of atypy in their family. But the bottom line is that these things do not seem to change the duration of illness or rates of admission. Hypertonic saline, we didn't even get into, but same thing. And continuous pulse ox is not necessary. We worry when kids are under 90%, but otherwise we can live with it. We shouldn't be doing steroids. Chest PT doesn't seem to help. And antibiotics should only be given when we're confident that a patient has a bacterial infection. It otherwise does not improve bronchiolitis. Make sure the kids are staying well hydrated. Nobody should be smoking, and we should be encouraging breastfeeding. Sorry, I'm going very fast with this. So what's the bottom line? And I'll end with this. So if you have a patient with bronchiolitis, they're otherwise healthy, are they well hydrated? Are they breathing comfortably, regardless of how they sound? How do they look? Are they saturating above 90%? If the answer is yes to those, suction, supportive care, and they're okay to go home. And with that, I will end with just a couple of minutes here for questions, comments. Thank you very much, everybody, for your time. Hopefully this was informative and helpful.
That was extremely informative. Thank you so much, Dr. Russell. So we did get a couple of questions in while you were presenting. The first one came in. The question was, can asthma get worse if you have bronchitis?
Good question. So certainly viral infections can trigger asthma. We know the viral infection is the most common trigger for asthma, and they can overlap. So those are the kids that are, that are older, that you're worried maybe more of an asthma picture. That 1 to 2 year age is really hard because sometimes what we see is that they respond a little bit, but not well, or not all the way. And so for those kids that may likely are going to go on to develop asthma, but like I said, those are the kids that are like, everybody in the family has asthma, child has eczema, maybe they have allergies. And those kids are probably going to be the ones that are more likely to respond. And while you can't give them a diagnosis of asthma, they may be the ones that go on to develop asthma. But at this point, we don't have any way to predict it other than, that family history making them more at risk. So it's possible that, viral bronchiolitis could trigger somebody's asthma in somebody that is going to develop asthma down the road. But again, this is like the almost 2-year-old, right? This isn't the 4-week-old.
Right. Thank you, doctor. And if you could advance the slide. Yeah, right to the evaluation. Thank you so much. Just to remind you guys to please complete your evaluation, particularly if you want to receive continuing education. We're going to move on to the other question that came in, which is it etiology always an infection, or could it be due to an allergen in the environment?
For bronchiolitis in particular, it's generally defined as a viral infection. So I would say for bronchiolitis, it really is due to an infection. Truthfully, with little kids under the age of 1, we don't see a lot of allergies in these kids. You really kind of need a couple of trips around the sun to be primed and develop severe allergies. So, I would say most of the time, I don't know, in the ER at least, we blame a lot of things on allergies. We have kids all the time where, the 4-week-old is sick and the parents, you ask, is anybody else sick in the family? And the mom's dripping with snot and she says, oh, my allergies are acting up, like they have a cold. So, I would say, especially in the little ones, I would, especially in those that also have fever, I would really think of it as an infectious etiology and separate from allergens.
Thank you so much, Dr. Russell. So while you guys are doing the evaluation, if you could go to the next slide, I'd appreciate that. And just to quickly, just to give you some information on some resources. So we want to make sure that we've been hearing a lot from people that they can't find vaccines for their kids. So just to let you know that we will be sharing there is this website you can go to, www.vaccines.gov/search, and you can filter here by pharmacies that actually provide vaccines to children. And you can also filter by pharmacies that are connected to the Bridge Access Program, which provides vaccines for little or no cost to people that are not insured. Next slide, please, Doctor. Quickly get through these. Please check out MCN's frequently updated COVID Hub. It gives you access to a variety of resources around vaccination. That includes outreach materials and printable handouts. Next slide, please. Also check out MCN's award-winning FAQ, also developed to answer questions that we had from clinicians in our network. And this is also very frequently updated. Next slide. And then just check out our videos that go with our FAQ. That's all I want to say about that one. Next slide. And then just a reminder, you can connect with MCN through a variety of social media platforms and also by attending our webinars and accessing our resources and so forth. So with that, I want to say thank you to everybody for joining us. Thank you so much to Dr. Russell. If you have any questions, you can always email me or email Dr. Russell about any of the material that was presented today. A quick reminder that I will be sending a follow-up email to everyone. In the email, you're going to find the links to the recording in both languages, the links to the evaluation also in both languages, and I will provide you a great deal of resources as well. So thank you everyone for joining us. Thank you again, Dr. Russell, and we hope to see you guys at our next webinar. Have a great evening, have a great afternoon, everyone. Thank you.
Thank you, everybody.